Good morning, Michelle. This is Victor.
Oh, it's good afternoon here, Victor.
I'm sorry. Yes. Time flies.
No
I'm
problem.
on.
No
All
problem.
right.
Good to see you. Oh, I see your face. Don't
I
see
mean, yep, I'm on.
me. I'm going to count the number of Brenda Rices for today. I have two so far. Two so far. Let's see.
Yep.
There's Jim. And let's do the chat box. So we have every facility and individual. And I'm happy to report Karen Vleck is completely up to date with this information for ECHO. They're happy to know that. So we want to get this in real time today as well. And Darlene Shoemaker, glad to have you with us from Clarent, our quality improvement organization. Our CMS Medicare dollars at work. Right, Darlene? There's the real Brenda Rice.
Dr. Gill will be joining us here shortly. She's running a little bit behind.
I know the feeling.
But I think we have everybody's names
Yeah.
from our group now corrected.
There we go. Does every computer in your facility pop up with your name initially?
You know, like I said, everybody gets more out of my name than I do. I use my name and I get nothing. So.
Oh, I love it. That's right. My fax scanning machine went down. It seems to have lost the network, and I'm totally lost without it. So, and you would think that in this great world of Johns Hopkins, somebody could figure out how to get it back up, but not yet. Not yet. Went out on Friday. So, so I'm resorting to tiny scanner on my cell phone. So, all right.
Not helpful.
Yeah. All righty. Okay. And I know our Julia Manor folks are here in spirit. Don't see you physically, but see you in the chat box. So glad to have you with us. And we're looking for our future care folks. Let's see, Canton Harbor, Kim is on. Good. Looking for Dr. Shake and our North Point crew. Don't see them yet. And I don't see Karen on here. Let me remind her. Oh, there she is. She's connecting now. Okay. All right. Okay. We have one telephone number down here, 410-342-6644. Is that somebody who's also on video? 410-342-6644. If that's you, and you can put it in the chat box, that number is Canton Harbor. Kim, is that you, or is there someone else from Canton, or you're not sure? All right, and Karen Vleck is on. So Karen, I know everyone has put their names in the chat box. We have, it's Kim. So Kim is also Kim Bates from Canton Harbor is also the phone number 410-342-6644. So that is not someone separate. And Karen, are there any emails or that you need or facility names for this Tuesday afternoon cohort? I know you've been working on our Thursday cohorts to reconcile everyone. Can you put in the chat box if there's anybody that you need?
Can you hear me?
Yes, we can. Mhm.
Oh, great. I think we're pretty much up to date. A lot of the people that we have not received a facility name from appear to be corporate folks. So I'm not really sure how we're going to enter them into the system yet, but
Okay.
I'm waiting to get some kind of response.
All right, those are our Thursday folks, but not relevant for this session then. Okay.
Correct.
All right.
Yeah, I think we're okay with this session.
Smaller group. Okay. All righty. Well, today is our session on safe visitations and reopening. So I'm going to share my screen. And let me get to close those things and bring up my PowerPoint. And let's begin from the beginning. And with that, I'm going to start by reviewing the February 11th order from the Maryland Department of Health that spoke to a number of our COVID policies, regulations, but had a specific update with visitations. And then we'll move to our discussion of safe visitations and our plannings within our own facilities. And just to highlight, our next week's session is the role of CNA, and would love to invite every facility to have a CNA, if at all possible, join in the call and share their perspective of COVID care. And certainly have an opportunity to acknowledge the great work they're doing and hear from them. So this is February 11th, 2021 update to all of these different governor's orders, executive orders that began back in March 16th of 2020. I guess we'll have to celebrate that date next month together, because that'll be our last week of sessions. And in fact, that'll be the Tuesday. That'll be our last session. So we will be finishing a year after the governor placed his first directive with respect to nursing homes and COVID care. And there are a lot of updates here, all our PPE, our reporting, our testing, but last week's update had a big section on visitations and reopening. And so as of March 1st, we can resume our visitations beyond compassionate visits as the February 28th order expires, and highlights the CMS guidance for nursing home visitation, and we'll review that in just a moment. But I did want to show the note there at the bottom where nursing homes are encouraged but not required to either test or ask visitors to show proof of testing, and there's no specifics as to the time frame, so we certainly can be discussing that during our session today. So this is the subsection that expires, and it, with the indoor visitation of requiring the 72 a COVID negative test within 72 hours, but does still in the CMS guidelines still has the different community prevalence rates guiding our approach. And the key numbers here are less than 5% is a good community rate where visitations will be more open. The 5 to 10% is where limitations in the number of visitors at any one time in the facility, and greater than 10% not being permitted. So here is the CMS directive that it's referring to. And I wanted to specifically go to some of the recommendations here. And while not required for visitor testing, in the medium, which is that 5 to 10% community prevalence, or the high positivity rates of greater than 10%, encouraging the testing, but not requiring it. And giving some guidance of suggesting within 2 to 3 days if one is going to require negative testing, but we also recognize within our own geographic areas the ability to have results within 2 to 3 days of a negative test is very, very challenging. I did want to also highlight CMS's guidance on compassionate care visits. But they highlighted not just the end of life care, but when a resident's well-being has been compromised, such as unplanned weight loss, dehydration, not eating, drinking, when there's mood disorders, more frequent crying, behavioral issues, and when there's been a loss within the family and needing that type of one-on-one communication that can only be done in person. And then giving some guidance about, while recommending social distancing, but in fact looking for personal contact, perhaps through offering PPE, but certainly hand washing and masking being required for indoor visitations. So I just wanted to share, I know we're all very, we're used to going to these orders and guidelines and directives. So this is what's in writing, what's going to be applying to us now in just a few weeks as the Maryland order evolves for March 1st. So with that, I'm going to stop sharing my screen and invite each one of our facilities to talk about where you are in this planning and what challenges in particular. Actually, I did put a few questions up here. Let me just, forgot there's one more slide to go to those questions. Sorry, let me go. Some of the challenges particularly related to the logistics of scheduling, particularly if visitations are limited to 5% of the residents at any one time. One of the areas I was asked to really think about and lead discussion for our Thursday groups is setting the culture of visitations. Our staff have been have not had visitors in the building for almost a year, and bringing them back and having the staff comfortable with more individuals in the facility at any given time, and how workflows will change as a result of that. And then thinking about the PPE use and particularly the compassionate visits and the challenges of social distancing while offering that type of care. So with that, I'm going to stop talking and ask for a volunteer to kick us off in our discussion today of safe visitations and reopening, taking any of those issues or an issue that you yourself feel is raising to the top as you're planning for reopening.
Volunteers.
Hey, Jim, thank you.
All right. Yeah, so we're obviously getting ready for opening. We coincidentally closed our outbreak today, which has been open since October 7th. So, and even before that, it was only closed for a couple of days and we were in and out. So we haven't had any indoor visitation. We've had window visits for a long time. So we are sending out a letter today that we will be converting some of our window visits to indoor visits. And we're doing it baby steps. We're doing slow, one at a time. So we have a designated area in the facility that if the family member chooses, we'll allow one visitor in for a 20-minute visit with the resident, of course, both in PPE. We have a table set up with a plexiglass shield, and we will test the visitor prior to the visit. So that's probably been one of our biggest discussion points, you know, based on the guidance that came out, is will we test visitors prior to? And we will require a test, and we will provide a test if requested. And we don't have a shortage of POC supplies, that's for sure. Thanks to Maryland and HHS, we have a lot of boxes of supplies, so we might as well put them to use. So that's what we will be using it for. So they can either get a test prior to coming in, POC or PCR, and provide us the results before the scheduled visit, or they can come in. We're setting up 2 days, I think it's Mondays and Friday, or Mondays and Thursdays for from 12 to 1, which will be our free testing for future visits. So they can come in, get their visits, get their test, get their negative.
Jim, we lost your sound.
My back?
Yep, you're back.
All right. So as I've said, they'll have 2 opportunities to get a free test if they want one, and then they'll be eligible to do an indoor visit at the facility. So we have with our window visits, we have a software that we're using for scheduling, so family members can self-schedule, and we can manage it on our end, and then we'll be able to see if it's a requested window visit or in-person visit. We can check off if they've provided testing results and go from there. So we'll start it, as I said, we're going to start off with 1, and then we'll grow it from there. Our biggest challenge is, of course, with everybody else, it's all these space challenges, is how to manage, all these requirements. So now you have to have indoor visitation, socially distanced, and at the same time, you're trying to open up dining rooms and activity spaces that are break rooms, and it's just trying to get it all, figuring out how to all make it happen, and none of it could happen fully. It's all happening on a limited basis, I guess. So, so I guess that was probably the biggest discussion with our corporate team, is around the testing, and if we're going to require it and if we're going to offer it. So,
and thank you for that thorough review. The software that you're using, you've taken a scheduling software and made it work for visitation.
yeah, it's called Acuity Scheduling, I believe, is the name of it, but it's pretty cheap and it's real easy to use for families, and you can customize it pretty much any way you want it on our end. So,
and so you've shared the links with the families, and then they schedule.
Yeah, most of them. Some of them will call if they're not savvy, but most of them will utilize it.
Okay. Can you tell me a little bit more about your window visits right now? What does that mean?
It is what it is. It's a glass door, and we're on one side and they're on the other.
Really? Can they talk to each other? Can they hear each other or not? Oh, we can't hear you again.
Yeah. So we have a telephone. Can you hear me?
Yeah.
Okay. So we have a phone on each side. So we have an activities staff who will bring the resident down to the designated room that has the window. On the other side, of course, outside is chairs and an umbrella if needed, where the family members will sit, usually stand, and then on their cell phone can talk with the resident. It's a 15-minute visit. Usually by 15 minutes, everybody's had their fill, and they're standing outside, of course, but it's nice. I mean, a lot of times we'll have like 10 family members will show up, so we don't limit. There could be a bunch of people outside the window. It doesn't matter to us. And they'll bring birthday balloons or signs or different things and be able to talk with the residents. So it was better than nothing at this point. So it's been pretty popular.
Do you allow those family members to bring things for the residents when they come to the window visits?
No, not typically. So anything that would have to be brought has to be approved and dropped off and quarantined to some degree. So.
Okay. All right. Very good. So with your actual designated visiting room, you've decided to do a table with plexiglass. So you are doing the social distancing through the furniture, right?
Right.
Yep. Very good. Okay. Do you have a sense of the number of family members who will ask for the testing rather than provide their own?
I'm guessing most of them get a free quick test as opposed to going to an urgent care and having to pay for it. And, so I imagine most of them.
And do you have a sense of how many of these visits per day you'll be able to do?
I think we have about like 8 slots scheduled per day right now. So 8 to 10. And
your census of how many residents?
Oh, about 150.
So,
like I said, it's a start. And then we'll eventually, I anticipate we'll do that for at least a couple of weeks in February here. And then we'll get to March. And then our next plan is to graduate into a dining room and set up multiple stations, multiple tables, similar design, but be able to do like 4 or 5 visits at a time. And really be able to increase the program. That would be our next step.
Good. So you're going to start with your single area one at a time, but with the intent of having multiple. Very good. So you've thought through this quite a bit. How about the staffing it's going to take for these visits?
Yeah, that's the other challenge, of course. So we have our activity staff is mainly providing the support at this point, but they're balancing, a lot of FaceTime virtual visits. They got a pretty full calendar with running around doing those on a daily basis. And now we're pulling away from the staff so they can help transport residents. So it'll be all hands on deck. There's some things that does take time, but there's still things that don't take time. We don't have 40 visitors in our facility that are all over the building, demanding time and taking time from staff. So there's a lot of things that they don't have to do now. So now we'll require some additional transport to get them to basically an appointment on time.
Mm-hmm.
So it'll just be additional staff coordination.
Sure.
And I guess testing going from twice a week and that being optional to some degree, but we're going to do weekly testing at least for the foreseeable future. So that, frees up a whole nother round of testing, which admin team and other staff members were tied up in doing and tracking. So there's a little bit of give there, which is helpful.
Good. So less staff testing time, and that staff can then be redeployed to indoor visits. Yeah, good. All right. So you've been doing lots of planning. So when does all this start for you?
Thursday will be the first potential indoor visits. And then our beautician is back tomorrow too. So that's probably bigger news than indoor visitations. So we're going to open up the beauty shop again and are planning that as well.
And are you, as that directive, I don't know if you saw the very first page of the order, specified beauticians are considered vendors. So your beauticians will be tested like staff?
Yes. Yeah, she'll be added to our roster as of tomorrow and will be bi-weekly tested, and then weekly, whatever the facility requirement is, she'll follow.
Great. Very good. So you've identified space challenges and staffing challenges, but you've done a lot of work towards scheduling. But still, there are the folks who need the phone calls and the scheduling phone calls. And I'm sure you'll have a few folks show up who didn't get tested and didn't know they needed an appointment, but you're open, aren't you?
Yep, we're trying. So that's, we need to show that's for sure.
Good. Well, thank you. Thank you for kicking us off, because you appreciate that. All right. How about my great friends from the Hebrew home? But I wasn't going to mention Brenda. I was going to ask Sadie if maybe you could tell us about thinking about what worries you most about visitations.
The volume, because of our size. Yeah, so that influx of family members who's been anticipating coming in to see their loved ones, coming in all at once, and being that we don't only have one building, we have two separate buildings, just managing the two areas and making sure that we have a smooth transition, keeping things orderly. And and maintaining, of course, our stringent infection control practices so that we don't, go back to square zero, if you would call it. Yes. Yep. So that's what it is.
And where are you in outbreak status right now, Penny?
So we were actually free for about 3 weeks now. Yeah, about 3 weeks. And then this afternoon, we learned of one positive case, one case. You admission on a rehab unit, 16 days inpatient, and tested positive today.
I hope the patient didn't come from my hospital, but that's the challenge, isn't it? Where a single case makes a difference.
Yes.
Yeah. Okay. Have you identified space for the indoor visitations for your two separate buildings?
So, Sadie,
I'll let Brenda take this one.
I was waiting for you, Brenda.
I was going to say, I'll jump in here. So we do have areas set up with, in our social halls that will have plexiglass there. You'll have to be on one side. It's a full setup, and the resident will be on the other side. We also use a scheduling product called Appointment Plus to schedule, and we will be using that to also schedule indoor visitation once we can get there. We currently do, as the same as Jim, we use it for our window visits. We do have phones on the inside that they can talk with their loved one on cell phones on the outside. We also have heaters outside because outside of one of our building residents, we actually have a bubble kind of for chairs in it that the family member can sit in for their window visits. So we are probably similar to Jim. We're actually in the process of we have the POC. I like his idea of testing twice a week, and then how do you do that? And again, because as Sadia said, sheer volume. You know, for us, it's, you know, it's a lot.
Brandy, do you think you're going to get some pushback once family members start saying, look, here's my card, I've been vaccinated?
So we have weekly town hall meetings with the families, and nothing in the reading so far that has come out has said that just because you've been vaccinated means you don't need to be tested. And we've been very clear about that with families, because it's like, well, I should be allowed in. That, you know, vaccinations, and I'm sorry, I can print those cards out and hand them out. You know, they really, they're really, you know, it's, you know, we can start peddling them on the street.
Oh my goodness, there's a new market for us.
I know, really, I just thought of that. Maybe that's my new,
Oh goodness.
Subsidize my income.
I didn't think about that, yeah.
Yeah, so those cards to me really are not, you know, the validity of them is, it's like, how do you validate that?
Sure.
So
I hear you. Actually, I hadn't even thought about that, to be honest. I know people I see people coming down the elevator with a vaccine site here on our campuses in my building, and people are in the elevator with their cards. They're taking pictures of their cards, sending them to family members. But I hear you. But it sounds like you've been doing a lot of education to say, while we encourage the vaccine, it is certainly a step toward lowering our community prevalence and reducing our risks of outbreaks within our facility that will allow us to go to indoor visitations. The reality is it doesn't change how we do those visitations at this time. So I hear you.
So about 90, we're probably around 91, 92% of our residents in the nursing for the Heber home have actually received their vaccinations. And we're over 60%. And our numbers, we just had our third clinic this past weekend.
Yes.
So.
Fantastic. Good. Keep going. Yep. Are you seeing some staff that were not vaccinated the first two times were part of your third clinic, with seeing what's happening in the community?
Definitely.
I'm wondering if what's happening on the national news right now with New York and reporting on nursing home deaths in New York, whether that will have some help family members understand the challenges we're all under in our long-term care settings. What do you think? Have you heard much about these reports from yesterday and in particular yesterday, but I think it started Sunday with Governor Cuomo's issues?
And I can only speak for the Heber home. I know, you know, our numbers, we've been very transparent. We've had them from the very beginning posted on our website. And again, because of having our family town hall meetings, we've been questioned every step of the way, every week on our numbers. Why are your numbers higher? You know, and we have a lot of families that live in the New York area. You know, what are they doing that's different than you? And it's like, I don't know. I just know what my numbers are, and I trust my numbers. I can't validate somebody else's numbers.
So you've been reporting deaths that occur in the hospital from your long-term care residents or short stay residents that were transported back because of COVID, where and that's what they were not doing in New York.
Correct. So, and we'd actually gone back and looked at we knew that Dr. Gill probably several months ago, we had actually looked at their numbers because we were getting compared so often that, and you could tell what was going on.
Okay. Are you also in your spaces for your indoor visitations? Are they one resident at a time, or are you looking like Jim to try and find a way to do more than one resident?
We'll be able to, we have it set up that we'll be able to do several at one time.
Is anybody thinking about activities or group activities in these rooms, or at this point it's just a visit with a family member? They're going to talk to each other. They don't need music. They don't need refreshments. We don't want them taking their masks off. Is that pretty much what you're planning in terms of these visitations?
I'm gonna, for us, it's really just a social visit, not, we're not going to be allowing families up on the units. That will come down the line. So
Is the space that you have planned, is it near an entrance, and so they really are not moving through the facility? So
yeah, they're all on the first floor, on the first level. We're multiple. We have one residence that's 5 stories, one that's 4, so we can keep them separated.
And you can keep them in the first floor? That's great. Yeah. Our vaccine, we have the 4th floor empty. I used to be in a skilled nursing facility transitional care unit. That's where our vaccines are. But we've noticed a lot of folks in our elevators right now and have said, there's a conference room not being used in the first floor. The answer was they didn't feel it was large enough for the number of vaccines they're giving each day. And so that's why there's a whole floor. The spacing is beautiful, but it does require more folks in the elevators. So trade-offs that we have based on our spaces. All right, thanks. What worries you most, Brenda, about increasing your indoor visitations?
I think, what you brought up earlier weighs heavily is this, we've only been working with each other. It's, bringing in visitors into the residence and having them moving around. We've gotten pretty accustomed to not having them, family members in the residence. So, welcome, bringing them back in and being okay with it and having the staff be okay with it. It's a little scary.
Are there some basic things like, the morning care and dressing and whatnot? Do you have certain hours for your scheduled visits so that you can accommodate, they've got to look their best, I guess, right?
We will have, and again, as Sadia said, because we were getting ready, getting ready to go, and with the one popping up here is a positive, kind of sets us back a little bit, but we'll have scheduled times. And again, using Appointment Plus, it makes it really easy. The family can pick their time. The unit will be able to see that schedule and be able to bring the resident down to the area.
It's almost like our rehab schedules where everybody knows the schedule for the day, who needs to be ready when to.
Yeah.
And do you also have the beauticians coming back?
We actually started today with beauticians coming back in. So we started having them testing last week, and then also agreeing to be vaccinated.
Good. Karen, I think you're unmuted, if you wouldn't mind muting.
Yep, sorry.
No problem, thanks. All right. And the culture for staff, then, do you anticipate that, so a visit's happening on the first floor, and the family member says, gee, mom looks like she's lost weight. Could I speak with her nurse? Do you anticipate some of that type of wanting more clinical information at the time, not just a social visit with mom, but I want an update. What's mom's med list and all those sorts of things?
Sure. I actually don't anticipate it to be much different than what our window visits are right now. It's kind of one of those, when you first set them up, it was like everybody was gung-ho, and then it kind of weaned off. I don't see it being much different. It's probably going to be the same family members, So they can come in the door now, and it is, it may change if we're offering POC testing, that more people will want to come visit their loved ones.
Get a test before, or I've gone out of town, I'm coming back Monday, I'll get my test, and I'll go visit mom.
Yeah.
Yeah. Okay. All right. Well, thank you, Brenda, and Sadia for sharing your planning. Very good. How about my Julia Manor team, Jared and your team, Jennifer? Can you unmute? I can't see you today.
Michelle, it's Jared.
Yeah. Hey, Jared.
How are you?
We're doing well here. We're having these same conversations.
Good, good, good. Well, so let's see, about 2.5 weeks ago, we were cleared from our outbreak. We had been in an outbreak since mid-October. And then 3 days later, we got a positive staff member. So one isolated positive staff member put us back into outbreak status. So that's where we remain right now. But we're excited about getting our indoor visits up and running. We have a designated spot beside our lobby where we're coordinating these. And from a complication standpoint, we kind of have the same issues that everyone else does. The staffing part is an issue. The scheduling conflicts. I know we've got families that I've gotten 3 or 4 calls already saying that Governor Hogan says I'm allowed in on March 1st. So kind of have to democratically explain why they can't come in just yet. And but once we're cleared of our outbreak, we're looking forward to getting these set up and doing it the right way.
Good. What have you decided about requiring or not requiring testing of the visitors?
So our company policy is to have a negative test on file within 72 hours. If they do not have that test available, we will be POC testing them. Again, just another safety precaution for our staff, for our residents. But yeah, that's the plan, and families are aware of that. I've tried to let them know via our weekly letters that to anticipate this. And I mean, I've had no complaints so far.
Good. And will you do the POC testing on certain days, like the way Jim has set up Mondays?
No, but I love that idea, Jim. So I actually wrote that down, and I'm going to take that to the table to our corporate folks. I love that idea, because anything we can do to further coordinate our efforts to set up an organized visit and less hassle for our families with all they've been through, that's something we would certainly love to entertain.
Good. Jim, have you also made some provisions for family members that say can't do 12 to 1 Monday or Wednesday, or that's it, they'll find a way?
Not yet. So we'll see how it goes. I mean, that's our concern. You know, also we're concerned about people just using it as you were saying earlier, I think just to get a test. But they have to have a visit scheduled in the app in order for us to do the POC test. So if they are not having a scheduled visit, we're not going to do the test. So we'll see how the time frames work out. If we get complaints, we'll see if we maybe can juggle those times. But hopefully we'll put the burden on them. At least we're making it available to them. We'll make it work. So
what about the logistics of doing the POC testing in real time before the visit? Is that just nightmarish?
That's our concern, is that just takes then somebody managing that process continually. We may not have a choice. Maybe when we get to having multiple visitors at a time, you know, the advanced testing may become too much of a hassle. I'm not sure, but we want to have it done and checked off, and we know that we have a good test on file prior to the visit occurring. So the person trying to manage the visit and trying to make sure it happens on time, so all the dominoes of all the other visits don't get thrown off by somebody then needing a POC test, and now they're not available for 15 minutes, and then the visit gets delayed. And so that's why we're trying to keep it 2 separate events.
Sure. No, understood. These are some of the challenges that we've had some time to think about. One of the few times in COVID care we've had opportunity to plan ahead. So it sounds like you've been doing a good bit of that. So terrific. All right. Let's hear from Canton Harbor. Kim, are you able to unmute? And if not, let's see. Anyone else here from Canton Harbor? Let's see. Ryan. Ryan Barrett, are you able to unmute? Yes.
Yep, I'm here.
And you are from?
North Point.
North Point, I'm sorry.
Yep, Future Care North Point. No, you're fine.
Okay.
No problem at all.
So tell us about Future Care North Point and where are you in status? Are you in outbreak status right now?
Yes, we are. We're in outbreak status at this time.
Mm-hmm. But have you begun to plan for reopening and visitations, for indoor visitations?
Yeah, absolutely. We were doing it previously before kind of the second wave hit, if you will. We were planning for indoor visitation. We have a whole sectioned off area in our first floor dining room that we can do indoor visitation and be able to space it out. And it's actually separated from everything else. So we have an entrance and an exit. And that way you wouldn't have to go through the facility in any way, which we think is beneficial for obvious like spread reasons and any concerns there. So yeah, we're looking forward to be able to do that. We constantly let families and residents know that it's our goal to be able to get to that level because we want people to be able to see their loved ones and to be able to interact in person. We know it's been a long haul throughout this whole process.
Mm-hmm. Mm-hmm. I'm familiar with your geographic setup. Where are you going to be doing your indoor visits?
So it's right on it's the glass area. So if you know outside where we have the awning.
Yeah.
So you'd walk in through the patio there and then you kind of walk and weave your way back through. You'd be able to sit there in our first floor dining room and then you'd exit on the side of the building.
Great. So you have a nice geographic setup for this. So, and that'll include your second floor long stay residents will be brought down for those visits?
Yeah.
Yep, that's correct. Because it's right outside of the elevator right there. Yep. So it's not a long haul at all. So
are you, what's your planning for visitor testing?
So for testing, what we've done before, because what we did whenever we had people back for our second vaccine clinic, it actually worked out really well, where we did the testing on the side of it was kind of like a drive-by testing. And because obviously, like everyone's saying, you have to wait those 15 minutes to be able to get those results back. And especially with inclement weather, it's cold, it's raining, whatever may be happening. We don't want to make people freeze or do anything like that. So we've been doing it in the car, and then that way we've been able to let people sit in their car, stay warm, notify them after the 15 minutes that they're fine to come in. So like everyone else is saying, it's just about planning and making sure ahead of time that so making sure we have appointments and a schedule and everything set up so that it flows smoothly.
And how are you doing your scheduling?
So we just have a time frame that's put into place. So so it's usually a 20-minute appointment. That way we can rotate through and everyone has an opportunity, because obviously when you have several residents and several family members that are all looking to make sure they're seeing their loved ones, we're just trying to make sure it's spread equally across the board. And then just making sure everybody's wearing the appropriate PPE, staying socially distanced. We installed a camera that overlooks the visitation area. That way we don't have to have somebody, right on top of people, but we can still kind of see what's going on and making sure everyone's adhering to what's necessary.
Good. Mm-hmm. And will you have more than one resident having visitation at a time in your space?
Yep. Yeah, we have 2 that are currently set up. So we have dividers in place and everything else. We have an air scrubber that's in there. So we can definitely do 2. We've contemplated 3, but we're definitely going to start on the safer side with 2 and just make sure that runs smoothly and then kind of move forward accordingly.
We haven't talked about is the cleaning of the space between visits. How is that done?
Yeah, so we have obviously the different chemicals. So we just looked at our kill times on what's best to use. I apologize, I don't have the chemical off the top of my head, but we have one that I believe is a 45-second kill time. So that way we're spraying that down and wiping down the tables and the chairs in between visits to make sure that everything's, that everything's taken care of and ready for the next visitor.
So
That's kind of built into our scheduling as well. What's that?
Whose job is it to do that cleaning?
So it's housekeeping's job to take care of that. But what we did is I'm sorry, I apologize. Whenever we were having our visitation prior, we actually moved our front desk person out to that area, which ended up being very beneficial. And so I think we'll probably utilize that because that way they can still greet everyone and have them, have things taken care of that way. Yep. Yeah. Take the temps and do all the necessary pieces there.
Yeah, good. Well, that's right. We hadn't even talked about the actual symptom screening for the visitors as they arrive. So, staffing are doing that as well.
Yep. Yeah.
Okay. Good. This session is very quiet on our medical providers. What input have you given? I see Dr. Gill first. Dr. Shake, I just see her lovely picture. But Dr. Gill, what have you had to weigh in on for this type of change in your facility practice?
Hi, everybody. Good afternoon. Well, I'm part of the core team that makes all the decisions and reviews all the mandates that come out from MDH and the weekly call. So I'm in with these ladies on all their decision making. So whatever it takes. Currently, I'm learning of the new positive case. So I'm talking with the doctor that has that positive case and dispositioning them to the appropriate place and doing contact tracing with that case. But yeah, I think it's really just keeping up with the MDH protocols. And as they change, we change, and being ready to be flexible, educating our families weekly on the town halls. I'm on the meetings with Brenda and Sadia. So I answer usually all their medical and clinical questions. And lately it's been about the vaccine and them wanting to know for themselves when, should they take it, not take it, and what's happening with vaccine. But really, I'm part of the core team that determines all the protocols. So nothing really to add from what they have already stated.
Terrific. Thank you. Dr. Shake, what would you like to add to that if you're able to unmute?
Unmute. I can certainly unmute and put my picture. I'm actually sharing the space with another colleague. So, so don't mind my masking. I hope you guys can still hear me. So for visitation, because I'm medical director, but also CMO, I have been involved in also, keeping up with the policies, updates from CDC, and then thinking about how we can make it as safe as possible. So we feel it's so beneficial for our patients, and our patients have suffered from depression and loneliness, isolation. So we are very excited that we would be able to, open up for visitation. And of course, making it as safe with the temperature checks, making sure visitors are screened for any symptoms, making sure that they're tested within the last 72 hours, which I think is going to be more so facilities doing the testing, because it's going to be hard for the families to get tested outside and then bring those results. So I think it's going to be more responsibility on the facilities. But I feel facilities are so excited about this that they are happy to take on that burden because, patient care comes first.
Yeah, thank you. Thank you. I just want to make sure Karen Black recognizes that you're on the call because you're not in the chat box. So we have Dr. Shake, and we also have Ryan Barrett just put his name up under Future Care North Point, Karen, to make sure we're up to date in our registration. So thank you.
Yes, I have them both on my list.
Good. Kimberly, I believe that I've unmuted you if you'd like to add to the conversation.
Good afternoon. Thank you. So we're planning like everyone else. Right now, we still are in outbreak where patiently awaiting our test results from today's testing before, we will be cleared. We had a pretty large outbreak over the last month. So we're doing setups pretty much like everyone else. We have a first floor dining room that we're planning on using, with the same safeguards. As far as testing, we will probably be doing the majority of the testing of the family members before they can come. I do like the idea of scheduling that earlier, a few days. I don't know, hopefully families would be open to that and making 2 trips rather than just 1. So we just have to see if that would work for us. Activities has been scheduling when we had outdoor visitation, as well as the iPad FaceTime calls, and they'll be doing the same thing.
Good. All right, thank you. I was about to say something. Oh, goodness. All right. We discussed early on about, as we see more that COVID is spread through respiratory and close contact. Any thoughts about the issues of family members bringing belongings, gifts, and do you feel it's just logistically too challenging, or you feel it's still an infection control issue?
So for the Heber home, we actually have allowed families to, before 10 a.m. drop off food, just as a kind of a, so it's not, food isn't coming in all day long. And then any other items throughout the day, we have a table set up in the airlock between the 2 doors that they can drop items off. And then we have staff scheduled to come down and pick them up and take them up to the room. So we don't quarantine. We haven't found that to be a transmission site for us.
Good. I think that's what the literature suggests as well, but it becomes a logistic issue too, and timing, and certainly understand that. I'm going to turn this over to Dr. Victor Bogoslavsky, our IHI expert in quality improvement. And Victor, what are your thoughts on our discussion of safe visitations?
Thank you. Again, great to be with you. But I was just as we were talking about this conversation, having this conversation, I was going through some sort of key blocks of the elements of the cause and effect diagram that sometimes helps to organize your thinking around an issue or a program. And then I'm just so thrilled that all of the elements of is being tested checked. We talked about staffing as people. We talked about the environment, the space. We talked about scheduling. We talked about materials that provide support, and the policies and procedures and disinfection and testing. This is all wonderful. And what is important, actually, we talked about the testing at a small scale first. And on that note, I actually would love to hear from you, Jim. Maybe since you're starting this week, maybe you can share your sort of thoughts and experience with us about how did you move from, or how did you start, and how do you move from a smaller to a larger scale? What type of challenges, what type of ideas being tested? I think this is such a wonderful opportunity for all of us to learn as we move into the visitation soon. So the time is coming, so I think we'll be all learning more and more about how to make this more accessible and move from a smaller to a larger scale. So that's I wanted to share. But I also wanted to share with you, this is optional, but IHI has just posted on the library the whole set of slides about QI tools that sort of ranges from the process improvement to the cause and effect diagrams and planning for changes and change ideas, and including even the time series charts and how to construct those. So I wanted to share this with you. I'm happy to put this link if you are logged into the IHI's library, if that's okay with you, Michelle. Maybe
Sure.
people can sort of take the value of it. But again, I just wanted to say that there's so much of thinking and planning has been done. Let me just see if that works first, okay?
Okay.
It belongs to the link, but if you can open that, you'll find it's like 100+ slides, but some of them are very useful, particularly on the process. But I think with this specific conversation, it seems like the sort of the fishbone, we call the fishbone diagram, could be very helpful to organize the, yeah, I mean, you need to download that sort of, it's an option.
I already did.
So
Okay.
the reason I wanted to share this, I think it helps us to work through as we move, forward. This will be useful to always make the reference to those kind of slides. And I'm happy to make another presentation personally, but I think there's a lot of look through the processes and go through the if you can scroll it down, you can go to the cause and effect diagrams. But clearly there's a lot of thinking has been done. So
But it seems like we've verbally done what you were
exactly.
saying.
You just run through that. That's exactly right. Thank you, Ms.
But you know what, Victor, for Thursday sessions, while people are talking, I might ask you to start doing a diagram like this as
Sure.
people are talking, and then I'll ask you to share your screen. So we've used our Tuesday group to help us think about how we might do better, but to actually, while people are sharing what they've done, and that's what you all did, was basically we verbally did what you're suggesting visually. But I might ask you to actually do that in real time on Thursday morning, Victor, okay?
Good.
All right.
Happy.
So group, we've got 4 more minutes. I want to spend 2 minutes talking about next week's session. So it is the role of the CNA. What role should we talk about and how should we talk about it? So help me with that one.
I guess my question is in reference to
COVID care. Everything about this is nursing home COVID, but the topic is, and I haven't looked at the planned sessions or the videos or anything. I just want to get a sense from all of you, what would be, when I mention your CNAs and COVID in a sentence, what opportunities do we have, or what challenges, or?
I think for me, Michelle, education bubbles to the top as an area of concern. It needs a lot of emphasis and it needs a lot of reinforcement. And I think just for that population, dedicated, focused education that sometimes has to be tailored and different from the curriculum given to other staff is an area of concern for me particularly.
And with respect to recognizing the symptoms of COVID, treating patients with COVID?
For me, it's much broader than COVID. I think it's everything, even thinking way back to SBAR and trying to do some education around SBAR with that group. We've never been successful to the level that I would like to see it anyway.
You know, this happened to me yesterday where a patient's respiratory rate was 40, and it wasn't recognized as being a clinical, got to stop what we're doing, that's abnormal. So that hit home for me when you said that.
Yeah, so I mean with COVID, it just has really brought more things to the light. But I think it's just a general, most of our GNAs are advanced age. I would say we have a good majority of them over 60. Wow. So it's a unique group where, you know, perhaps more modern technology and education that is not accepted very well by that population. So it's challenging, I think, just all areas of patient care.
Thanks. Any other thoughts?
So I would say for us, what we have seen is uptake of vaccine is lower among GNAs as compared to some of the other staff members. When I spoke to a few of them, I felt that there's a lot of misconceptions based on what's on Facebook and some of other social media. And we have been trying to educate them about, you know, some of the safety data that is out there about the vaccines, the effectiveness and how crucial it is for them to get vaccinated, especially because they're the front line. But it has been most challenging group among all the other staff members.
I will say that in my Thursday groups with Genesis, I do certain states in the morning and other states in the afternoon. They try to have a GNA representing each facility. Is it possible next week for you to invite a GNA who might want to share their experience of COVID with your facility leadership who are on these calls? Because this group tends to be the facility leadership rather than the frontline staff. But Genesis has throughout the sessions included a GNA with the intent that the GNA does go back and share with their peers what's happened in these sessions. So I'm going to invite you to do that. It may not be possible for your facility, but wanted to offer that for next week. And just please include that person on your chat box and put CNA so that I know obviously I know all of you since it's a small group. But if that's possible, I wanted to invite that for next week. One more last comment. I'd like to tell you that our daily reports of our community COVID, we get our hospital number of patients, number of ICU patients, number of open hospital beds. We get a daily report on our community skilled nursing facilities, our leadership here. And I just want you all to know how important that is, that our leaders are looking every day because you're reporting your data. They're actually reviewing it daily so that the partnerships are continuing through COVID care. So I just wanted to share that with you. So, okay, everybody have a great week. We'll see you next week then. Take care. Bye-bye now.
Okay.